Hello, welcome to today's section. And just like we've been doing usually, we will do practical things and relate them to literature or theoretical knowledge. One thing I find it quite distressing is if students are being taught something that they have never seen, and the only option for them is to imagine it. I don't put blames on lecturers, but the problem is the resources are not available. So some of these sections of videos is going to give you a clue what you should have known. And what I'm going to do today is to explain some very important clinical stuff and relate them to practical things. I'm going to introduce you to some few analyzers and how they work. The topics that we're going to treat today are the hemophilias A, B, and C. I'm going to explain the different types of von Willebrand disease as well. There are three analyzers that I'm going to introduce you to, and these are the rotational thromboelastogram, and that is the ROTEM, and we've got the thromboelastography analyzer. It's called TEG analyzer, and the last one is platelet function assay, which is the PFA analyzer. There are different processes that these samples go through before the analyzers produce a result, and there are different principles that these analyzers use to produce the results. Just for a clue, if you could be able to interpret the correct results, you should have a good understanding of the basis from which these analyzers are working. And that's exactly what we're going to do today. This section is just not for students. It's also for people who want to understand how these tests are done and then the disease interpretations of those that I've just mentioned. Because most of our sections are going to be this, I would urge you to click on the like button, subscribe to this channel if you're interested, and I believe you're going to love it because most of these sessions are going to enlighten you on some of the things that probably you do, but you don't have the full picture of what it means. And we will go on to some few slides, and as we go through, it will be quite interactive, even though I'm going to talk alone, but I will engage you on practical things that you will be able to put yourself along as I go. So without wasting much time, let's go directly to our slides and begin with our sections. Lovely. So this is our beginning slide, and of course we've got some few analyzers displayed here. These are very simple analyzers, but performing a highly complex function in the domain of the lab and giving a very good clue about platelet function and overall clot formation. Just to begin, this one is the thromboelastograph. There is a similar one called thromboelastogram, which is the rotational thromboelastogram known as ROTEM, used mostly on the ward for point-of-care testing in the bleeding episodes. Both of them have very similar principle, which as we go along, I will interpret both how the differences come about. However, they both give an overall functional of clot formation, considering the clotting factors, fibrinogen, platelet amount, and platelet quality, and also gives a clue if you are in any treatment that could compromise clot formation, and it's used in monitoring people who are undergoing intensive surgical procedures, especially heart surgeries, and if anyone is in a disseminated intravascular coagulopathy. On my right hand here, as you see, the name is just simple. It's a PFA 200. The full meaning is platelet function assay, and it uses platelet agonist and a lined up collagen to see how platelets are activated under shear pressure, and I'll explain it as we go. Just for the beginning, what you should know on the screen. The next slide that I'm going to launch here, as I've got here, is just the thromboelastograph, which is TEG. The TEG has got a cuvette sitting area, and in this, the cuvette sits, and this is the cuvette I'm speaking about. And there is an oscillating axis connected to a sensor, and this looks as that oscillating probe that has got a sensor, and it rotates over an axis at a very confined angle. And the whole difference between the ROTEM and TEG is that in the ROTEM, it is this oscillating axis that moves around to mix the sample in the cuvette, whilst in this TEG, this axis or the probe with the sensor is stable or fixed. The pin does not move, but this cuvette rotates within its sitting area. That is the only difference. So, explaining ROTEM with this diagram, there is a light emitting diode that is directed onto this sensor axis or pin, and the light that will pass through onto the sample through this probe or pin will be interpreted on a graph, and it gives a diagram based on when a clot begins, how large that clot becomes, and when it begins to lyse or break down in the process of clot formation. While this ROTEM uses the optical detection, the TEG uses the mechanical way of detection. It means no beam of light is directed onto the sensor. Rather, the sensor here would pick the mechanical activity, that is the viscoelastic hemostatic assay. Yes, that's the mechanism in which a liquid state of the blood is converted or solidified gradually as a clot is formed. So at first, when the clotting factors get activated, begin to form a fibrin strand, incorporate the platelet into it, and they form a solidified mass. The sensor is able to detect at each time the changes that is occurring in there. And of course, when a clot is formed, it changes from a liquid to an elastic state, and the sensor is able to interpret the graph with time. And even as it begins to break down, the higher solidified mass degrades down, and the sensor is able to detect that as well. And all are incorporated onto a TEG graph where we can explain it based on what the analyzer is detecting in the reaction happening within this cuvette. And it makes an absolute sense. So what we need here is that we've got our cuvette. Remember, the citrated platelet in the blue top tube has already had its calcium chelated because of the citrate. So we will need what? Calcium to begin the clotting. That is what we should know. Secondly, we've already got a kaolin. So the small tube will have a kaolin, and you will pipette 1 ml of your citrated whole blood into the Eppendorf tube that has got about 40 microliters of kaolin. The kaolin is the agonist that is going to activate the clotting factors. Remember, if a reaction is occurring in vivo within your body, you have got the prekallikrein, high molecular weight kininogen, you have got the factor 12. They are the contact factors that will be able to trigger an intrinsic pathway clotting process. We don't have that in vitro. So kaolin is a representative of those contact factors and is able to activate our clotting factors, change them from procoagulants into active proteins that are ready for clot formation. So in your first place, set this cuvette on here in the cuvette sitting area. You take this cuvette, set it here. Now you pipette 20 microliters of calcium into your cuvette. Already you have had your citrated whole blood prepared with kaolin. You pipette 340 of them into the cuvette. This is how the cuvette moves. So this whole cuvette with your calcium, with your citrated and kaolinized whole blood will sit in this cuvette sitting area. This probe is what is found at this side. And the whole thing that you are going to do after the pre-analytical processes is to regulate the up and down movement of this sitting area. So I'll click on this video and you'll be able to see. So it goes down, up and down, just like it moves. And once it goes up and it touches there, you leave it this way. So this is the testing position, and you turn this knob to the right side and you click on Start Test. So this lever will allow you to move down and up, and whilst you lift it up onto the sensor, you leave it there. This is another lever that turns right to a testing position, and this position now is a load position, and to the left side is called eject. That is when you don't want it to continue the reaction. For instance, if it gets to 30 minutes and you don't want it to go to 60 minutes, you can just get rid of the process and interpret it by probably multiplying the LY30 by 2 to get 60 minutes. So we won't go into that yet, but just to give you an explanation of that, that's what we mean. Now, you understanding how the test is performed is just a portion of it, but interpreting the graph as to clinical circumstance is a top notch, and I would be able to guide you on that, and you will do a very simple interpretation, also get good examples and elaborate on it. Yeah, so for the thromboelastography, just like I have spoken about previously, it assesses the overall coagulation process and the lytic stages. It uses kaolin, it's calcium used. The technique uses oscillating cap, you talk about that. And the pin is connected to a torsion wire and transducer to pick mechanical properties, just like I've explained to you already. So on the graph, this is the R time, this is the kinetic time, This is the alpha angle, this is the maximum amplitude, and this is the lysis at 30 minutes, which I'm going to explain it as well. And I will interpret it here, and we will get examples to solve so that you wouldn't be confused. So the R time is the reaction time. It is the time from which you started the test till a time where about a small thrombus is formed, which has a maximum amplitude of 2 millimeters. So if the clot begins formation, the R time has ended. So from the time you began the test to the time the clot begins forming, that is when we say the R time has ended, and it is precisely about your clotting factors. And in addition, if you are on any anticoagulant that's going to inhibit your clotting factors, it is likely then that your R time is going to prolong, because it is as if you are clotting factor deficient because of the inhibition. And the changes that will occur in the R time can be associated to if you are on such anticoagulant. And not forgetting this, some people are predisposed to thrombosis. We say they are in a hypercoagulable state, probably due to cancers or thrombophilia. So these patients also have clotting occurring within their system, and they can also have their clotting factors either already consumed or activated in the course of a test. So we can interpret it as well. So we will have a list of graphs that we are going to explain based on these things. Now, what is the kinetic time? I will launch this. The first one that you should see is this is the kinetic time. At the end of the R time, until a 20 millimeters of clot has formed. So your 20 millimeters is going to form within this angle. So let me get a pen and introduce to you what exactly I mean. So if your 20 millimeters of clot has formed at this point, it means that your K time or kinetic time should be from the time that the R ended to the time that the 2 millimeters formed. So where they have indicated the K time means that your 20 millimeters of clot, the size of clot, was formed at this point. So by the time the clot started forming, so a mass of with 20 or wideness of 20 millimeters was formed, was at this point. And that time between the end of the R time to that point is what we call the kinetic time. I will launch a real time graph. This is a proper graph that has come from a test that was run with TEG, not a graphical deduction. This is a real time. So you can see there's vertical lines that are drawing from the bottom of the two sides of the graph development or the diagram development. The diagram ended its R time at this point, if you are carefully seeing. So when the reaction began, it started from here. So the R time is the time between this starting point and where a clot initially began. So at this point, it means a smaller clot of a size that is able to give a 2 millimeters amplitude had been formed. That is when the sensor detects that the R time has ended. Now, immediately the R time ends, the kinetic time begins. At what time will a clot mass will be formed, which make a wideness or a width of 20 millimeters? So let's say it happened over here. So at this point, this height is said to be 20 millimeters. That is what we mean. The time from the R times end to the point where a 20 millimeters was obtained, this side will become the K. So now, if you look at the kinetic time carefully, the contributing factors is not the clotting factors, because once a clot begins here, the rest is your fibrin strands that are going to extend, accumulate platelets into it to form a mass. So the whole kinetic time is contributed by your fibrinogen, and also if you've got enough platelets. Because if you don't have enough platelets, even though your fibrinogen there is able to interconnect, but it can't incorporate more platelets into it. So amount of platelet is a key, as well as your fibrinogen availability, its amount and its quality is what makes the kinetic time. So because we are even looking at a mass at a width of 20 millimeters, what's going to add up to make the 20 millimeters? We need platelet in there, and we need fibrinogen. So if you explain this, it will give you an idea of the fibrinogen of the patient and the platelets in patient's whole blood. So that's what we are talking about. Now, what about the alpha angle? So I will launch this graph. when we talk about alpha, rule number 1, alpha means beginning. Rule number 2, the beginning of a clot. Rule number 3, what makes the clot stable and what traps platelets into it. Because when I was explaining the K time, I introduced to you that at the point where a smaller mass is formed until we get to that 20 millimeters high, that is when the K time comes in. But at the beginning, when a smaller clot begins, that is for the clotting factors, and then the fibrinogen level begins to interconnect and trap platelets into it. So what actually begins the base or the alpha is the fibrinogen. And when it begins, let's trace it by the horizontal pin, which has the sensor. This diagram I have drawn here is the same thing when you trace the horizontal pin at this middle to the point where the clot began. If your fibrinogen level is on high to trap enough platelet quickly, it means this arc is going to be very wide. If your fibrinogen level is less and it slowly traps platelets, it means that this angle is going to slowly enlarge. It means that when the clot began, the platelets began to be trapped gradually, and as it gradually goes on, the width or the size also widens, but it wasn't at a speed. This is very simple. So if your fibrinogen level is really high and active and is able to trap platelets so quickly when there is an injury, in this in vitro, it will happen that this angle will be wide. So this angle is going to be very wide here compared to what we have in the graph. So on this graph, you will see that the angle will come on this side, and the tangent that has been drawn are the dashes over here. So the angle between this tangent and the horizontal axis of the sensor or the pin is called the alpha. On a real time graph like this, look, when the clot began at this point, immediately a lot of platelets were trapped into it. So the base, which is the arc at the bottom of the cuvette, is really wide, very wide. Unlike where other graph, though on this same horizontal axis, we could have a very slow trap of platelets which can appear like this. Which means that when the clot initially began here, there were platelets gradually being trapped in here until we probably got to 20 millimeters wide, and from this time to the start here will be what? The K. So K will be this time, whilst the R will be the start time till we have this initiation. And from here we will trap more platelet into it and fibrinogen interconnection until we get to the widest clot that it can form. But look at this side. If you draw a tangent here, the angle it will form with the horizontal axis is very small. That is the alpha. The reason is because the fibrinogen did not trap quickly. There was low speed of fibrinogen activity trapping platelet, unlike this side, that all of a sudden it became so wider at the bottom that the angle here was so big. Therefore, the alpha angle depends on fibrinogen level, and we interpret this alpha angle in conjunction with the kinetic time. And as it's interpreted here, a higher rate or speed of clot formation, fibrin cross-linking. So it is the fibrinogen level that shows fibrin cross-linking, and the alpha angle is interpreted along with kinetic. I've stated that one already. What about the maximum amplitude? Yeah, so when I was explaining this graph, I explained to you that as platelets are trapped in here, the sizes increases and it goes on until the strongest or the widest clot is formed here. And this actually depends on how many platelets you've got, if they are normal, and two, if your platelets are quality. Remember that in the platelet ultrastructure, platelet has got surface glycoproteins, which are their binding site. You have the platelet glycoprotein 1A, 2A, and that binds to collagen. You've got the glycoprotein 1B IXV complex, and that binds to von Willebrand factors. And we've got glycoprotein 2B3A complex, which also binds to fibrinogen, and we know that already. So that's the qualitative aspect of it. And if you have the quality of platelets, the number, all right, we expect a maximum amplitude to be within the normal range. And as well, if it is defective or you have thrombocytopenia, you will definitely have a low height, which is the low maximum amplitude. And the final thing we talk on this graph is the amount of lysis that will occur, or breakdown of the platelets within 30 minutes. So from the time that the maximum amplitude is recorded, so this is the maximum amplitude, from this time to the next 30, the lysis that will occur within is what we call the lysis at 30 minutes, and that is under fibrinolysis. This occurs physiologically with tissue plasminogen activation. So in your body, if physiologically your body thinks that there need to be an activation of a clot, it can do that. And internally there is homeostasis, and tissue plasminogen activator is the homeostatic reverse to internal or intravascular clot formation. So it is activated and your clot is lysed and your blood thinness is maintained. Pathologically, when there is DIC, which is disseminated intravascular coagulopathy, there is concurrent clot formation and breakdown as your body reacts to probably a venom or a hirudin in a snake bite or leech, or those kind of incidents that can predispose you to DIC. So that is what we call the LY30, and this can be multiplied by 2 to give you the LY60, or you wait until that time is over and you report accordingly. Now, an interesting aspect here, we will have an assessment, and I will be answering the assessment, but you need to follow critically. Okay, this is the difference between ROTEM and TEG. I've already talked about it. This optical detection, this electromechanical detection. Sensor pin rotate. Here it is the cuvette that rotates. Ellagic axis is used as activators. I talked about kaolin when I was explaining it. Clot formation parameters, upper panel, and then clot formation parameters is lower panel. It's lower panel because it is the cuvette that sits in, whilst we use the light emitting diode. That's the LED light that goes on the sensor to detect the optical reactivities of clot. It is relatively shorter here, whilst it takes 30 to 60 minutes for that. Now, this is the assessment. So I've given you this graph. What do you think? This is what do you think? That is. If this line is the end of the R time. Beautiful. So here the R time is correct. It is ending on the right edge. And you see this angle is relatively wider compared to the rest. We are not comparing it to the real time because we are interpreting these graphical appearances. So here it gives us a bit of relatively wider angle at this side, which probably gives a normal alpha. And then the height here is fine, meaning the platelet level here is okay. And then it took quite a longer time before the lysis ended. So it means that the LY30 is relatively normal because it did not just lyse the whole clot quickly. So this could be a normal one. So this we say is a normal graph. Let's look at this. Here, this is the normal R time. Here, it has exceeded the normal R time. It's gone to this side. It takes so longer time for the R time or the reaction time to end, meaning that it's either we don't have enough clotting factors here, or there is an inhibition, which means the patient is on probably a heparin or an anticoagulant that is inhibiting the clotting factors from making an initial clot formation. So here, clotting factor deficiency, patient on heparin or any anticoagulant can happen. However, the time it took for lysis was okay, and we can say that this height is relatively shorter, but we know the problem is already here on the clot, so we can't really base on platelet insufficiency or thrombocytopenia. So here, there is either clotting factor deficiency or there is inhibition or inhibitors, heparin. Here, the R time is normal compared to the normal graph. You can see here, the R time is okay. We love that. Then what about the height? Let's compare this height to that height. You see, this is wider, so the maximum amplitude was so wider compared to here, which is really short. So there is platelet deficiency here. There's thrombocytopenia present here. However, the lysis time was comparatively to the normal one, it was okay. So there wasn't any problem with the lysis here. Now, when we get to the next graph, You can see the R time is normal. The wideness of the platelet is a bit okay. It's better than this one that we had an issue with platelet, though it's not as that. We can say there's a bit of insufficient platelet here. However, the most conspicuous thing we can see here is that the lysis ended so quickly. Yeah, so of course we have fibrinolysis issue at this site because the lysis is occurring so quickly after the maximum amplitude. So in a medical condition of this kind, patients are given tranexamic acid. Tranexamic acid is the amino acid lysine analog, or it's a lysine derivative. What it does is that it binds to the fibrin cross-link. It is the exact binding site of tissue plasminogen activator, or the plasmin binding site, where it binds to break clots into the large cross links where we measure as D dimer. It's not going to allow plasmin to bind. Therefore, that clot that has formed will be quite stable. So it prolongs this time instead of being broken down so quickly. So that's the reason why we give tranexamic acid, which is the amino acid lysine derivative. It binds to the fibrin strand. It prevents the binding of plasmin, and therefore clots are not dissolved so quickly. So just by the way. Now our next one, look, all of them is either having their R time ending exactly the normal or they are prolonged. But this one, it is happening quickly or earlier than expected. This state is called a hypercoagulable state, and it is pathologically named thrombophilia. It is the state where people are predisposed to clot formation like pulmonary embolism and venous thromboembolism. So the DVT patient, this is the situation that occurs. They are predisposed to clot formation. So their clotting factors are activated quicker than expected, and they are involved in clot formation. People who have their natural anticoagulant ineffective are unable to stop the coagulation to maintain hemostasis, and therefore they have their system exposed to this kind of graft. So this is what we mean. And for instance, people who have factor V Leiden, their factor V is Leiden, though it's able to initiate a clot, but it cannot be reversed because it is mutated. That leads to a very big problem of this kind. So you can interpret it if your graph looks like one of these. Now we have the last two. Pay attention. This hypercoagulable state we talked about, we have it here. And this fibrinolytic state that we talk about, we have it here. If you look, the reactions occurred quicker, and then the fibrinolysis also occurred quicker. This is the first stage of DIC. Disseminated intravascular coagulopathy is a pathological state at which there is a quick initiation of clot formation and at the same time an earlier breakdown of that clot. So this is the first stage of DIC. And remember, if you are in the first stage of DIC, for instance, a snake bite that has caused your system to form a clot and break down at the same time, as it progresses to the next stage, your clotting factors are insufficient because they've all been used within this initial clot formation. So now you are clotting factor deficient at this point, and it is prolonging it. And as it prolongs, still you are lysing them up, and this is the second stage of DIC. So immediately you see this side is abnormal, that side is abnormal, first stage of DIC. And the abnormality is because here there is a quick initiation of clot, that is the first stage, and then whilst it is prolonging, it is using up all your clotting factors. At a point you are clotting factor deficient, and still they are breaking down the smaller clots that you could even form, and this is the second stage of DIC. So you can interpret all this graph so easily, so simple. You shouldn't make mistake of it. We are done with TEG. We will move to the platelet function assay. Now your platelet function assay shouldn't be difficult for you. I'm going to use a very simple analogy to let you understand it. Look, this is the analyzer. It's very simple analyzer, and this is the cartridge. This is the cartridge holder. There is a cartridge and a cartridge holder. This holds the cartridge that we use for the analysis. If I move you on here, you see a gentleman having this cartridge holder lifted out from the analyzer, and this white thing is called the cartridge. That cartridge has an inner lining with platelet agonists. So there are three factors that contribute to platelet activation. We have collagen, we have epinephrine, and we have ADP, that is adenosine diphosphate. Yes, so it works in pair if there is a tissue damage, and of course every tissue damage will definitely expose collagen. So collagen is a universal agonist you will need. Now your next point is to analyze if the platelets are not properly activated to seal your injured tissue. Does it mean it is the epinephrine that you are deficient, or it is the ADP that you are deficient, because definitely collagen will be available. Therefore, in the sense of these manufacturers, they have two cartridges for each test. One cartridge that has the epinephrine and the other cartridge that has the ADP, but both cartridges have their inner linings lined with collagen, which means both of them will have collagen. Now, under shear pressure, when we say shear pressure, it is the pressure at which blood moves platelet toward an injured tissue, and that shear pressure activates platelets. So the manufacturers have mimicked that shear pressure by forcing your sample that you are pipetting into this cartridge to be forced through an aperture. So a small aperture will now represent where the tissue is injured, and your blood sample will be forced through it, and it has got the lining with collagen, and there is a reagent of either ADP or epinephrine. So whilst the sample is forced through that part, platelets get activated in the presence of collagen and epinephrine in one cartridge, and then collagen and ADP in another cartridge. Now, the time taken from the start of the test to the time where that aperture is sealed by the clot is called the time for that platelet function. So it is measured in seconds, and it has a reference range. So as the shear pressure is mimicked by the pull of your blood sample through that cartridge aperture, that is when the measurement occurs. So I will play this for you to see how it is, but the whole thing is that you will get your citrated whole blood, you will mix it properly, you will bring your cartridges, both the collagen ADP and collagen epinephrine, to room temperature for 15 minutes for them to come to room temperature. You set them on this holder, that is the cartridge holder, and you put them in here. So this is actually the test kit, but here I'm going to show you the maintenance kit. It is the same procedure of setting the samples on here and starting the test. So if you observe this side, you could see this is the sitting area, and there will be a maintenance request. If you observe well, he will set the maintenance cartridge on the testing area and request like he has done now, and he will request. So for instance, this would be the ADP and epinephrine, then it moves inside there, and this will be the start of the test, and it progresses. So the shear pressure, aspiration, everything will automatically occur within the analyzer, and we do measure that one. But the whole knowledge behind it is what I've explained to you, and we have also ended the platelet function assay.